Sean bienvenidos a un nuevo plano.
Bienvenidos a un nuevo plano.
Un nuevo viaje.
Un nuevo viaje.
Un nuevo viaje.
Donde la visión es bidireccional.
Bidireccional. ARI.
ARI. Exposición comercial de tecnología oftalmológica.
Introducing the Intensity IOL. We created an innovative algorithm, DLU, Dynamic Light Utilization. It allows optimal utilization of light, uncompromised eyesight with minimal side effects. Intensity is a high-quality lens with top production standards. With a lens profile that has smooth, symmetrical distribution of 12 steps with different heights, allowing it to adapt for maximum compatibility to the different states of pupil dilation and constriction. Intensity provides 46% less light loss compared to its competitors, allowing continuous vision starting from a distance of 40 centimeters and to infinity, with a defocus curve allowing 6/6 and beyond visual acuity. The result? Vision redefined. Intensity by Hanita Lenses.
Hello, morning from the sunny Alicante, and I'm proud and happy to present to you, to introduce to this special session conducted from Alicante about Hanita Lenses. Hanita Lenses is an innovative company from Israel that creates a new concept in continuous vision, which is going to be explained along this special session. I want to thank Joaquin Fernandez, Gerard Ford, and German Bianchi, who is co-chairing with me this session for this contribution. And the first speaker is Joaquin Fernandez with evidence-based functional classification of continuous vision intraocular lenses. Joaquin, you are the first to start. Thank you.
Bueno, pues queremos compartiros la clasificación funcional basada en evidencia de la lente de visión simultánea que desarrollamos y que la Sociedad Europea de Cirugía de Catarata y Refractiva, SCRS, la tiene como base para conseguir un consenso mundial. Ya está habiendo conversaciones tanto con ASCRS, con Asia Pacífico, para poder conseguir que podamos tener una clasificación global a nivel mundial y todos hablemos de lo mismo. Estas son nuestra declaración de interés que puede afectar a esta presentación. Y esta es la editorial de la que hablamos, que fue publicada este agosto por el Working Group de Visión Funcional de la SCRS. Estáis viendo presidente actual y electo de la SCRS, pasado, el editor en jefe de la Journal Cataract Refractive Surgery, y entre todos llegamos a proponer esta clasificación en busca de ese consenso global. Y fundamentalmente lo que buscábamos era pasar de unos conceptos que estaban basados en ópticos términos, como podía ser el de foco, a irnos a unos conceptos más funcionales de visión de campo, ¿vale? En ese caso, como estáis viendo, cuando hablamos de profundidad de foco, estamos hablando de un fenómeno óptico, más que perceptual, que estaríamos más bien hablando de la medida de la profundidad de campo, intentando así evitar confusiones con el número de focos que a veces la industria nos presenta, bifocal, trifocal, cuadrifocal, pero en cierta medida intentar mantenernos denominaciones que hayan sido descritas en literatura o que los órganos reguladores ya la hubieran utilizado, como puede ser el Extended Depth of Focus, EDOF Extended, o el Enhanced Monofocal, ¿vale? Los reguladores, como estáis viendo aquí, la ISO, e incluso recientemente, hasta este 2024, donde definió la subfamilia de Full Visual Range, estáis viendo cómo nos propone una serie de criterios que también nosotros hemos adaptado. Nos propone fundamentalmente el cutoff de 0,2 logmar, y ese también lo hemos adaptado, pero hay algunas subfamilias que no quedaban suficientemente bien representadas, como en el mercado podemos tener las monofocales Enhanced, que no aparecen reguladas por la ISO, y era nuestra preocupación. Todo nace en este paper en el cual colaboramos con el grupo de Filomena Ribeiro. Estáis viendo cómo realizamos un scoping review, un cluster análisis, un método estadístico que se usa en Machine Learning para identificar resultados similares e incluso poder crear diferentes grupos y subgrupos en ellos. Estáis viendo cuál fue metodológicamente el proceso, y los criterios de clasificación se dividían en dos fundamentalmente. ¿Cuál era el rango, el range of field que podía alcanzar cada tipo de lente de visión simultánea, y cómo era el decrecimiento de la agudeza visual entre lejana, intermedia y cerca? Con respecto al rango del range of field que podían conseguir, propusimos 2 puntos de corte, 0,2 Lormar como propone el órgano regulador y 0,3 Lormar como se proponía históricamente en literatura científica, que era como se definía la agudeza visual funcional, ¿vale? Y luego el shape, la forma en la cual va esa transición del range of field entre lejana, intermedia y cerca. Identificamos 2 grandes grupos, como vamos a ver ahora, y en cada uno de estos 2 grandes grupos 3 subfamilias. Estos son los criterios específicos para cada una de ellas. Lo vamos a ver ahora desarrollado de una manera mucho más simple, pero quedaros con los que había 2 grandes grupos: el partial range of field y el full range of field. Aquí lo vamos a ver mucho más claro. Fijaros, ¿cuál es el punto de corte para el partial range of field? Como estábamos proponiendo, puntos de corte de 0,2 Lormar y 0,3 Lormar. Sabéis que el 0,3 Lormar sería 0,5 decimal, 0,2 Lormar sería el 0,6 decimal. Bueno, pues si la lente, el range of field es menos de 2.3, se quedaría como partial range of field. Quedaros con el punto de corte 0,2 Lormar, que es importante, y para ese punto de corte menos de 2.3 dioptrías, parcial. Si adquiere para ese punto de corte de 0,2 más de 2.3 dioptrías de profundidad de campo, hablaríamos de la full. Parcial menos de 2,3, full más de 2,3 para 0,2 Lormar. Vamos a ir familia por subfamilia. En las parcial, si para ese mismo punto de corte 0,2 Lormar conseguía menos de 1.2 dioptrías de amplitud de campo, hablaríamos de las narrowed. Estas serían las monofocales de toda la vida, ¿vale? Si adquiriera una profundidad de campo de menos de 1.58, estaríamos hablando de las enhanced. Bueno, las que ya sabéis que existen en el mercado, las monofocales enhanced, y las extended, que serían las EDOF, adquirirían una profundidad de campo de menos 2.3 dioptrías. Monofocales, narrowed, menos de 1.2, menos de 1.58 enhanced, extended, menos de 2.3. Si nos vamos a la full range of field, todas ellas para el punto de corte 0,2 Lormar tienen más de 2.3 dioptrías de profundidad de campo. ¿Qué es la diferencia? La transición entre lejos, intermedia y cerca. Fijaros, aquí es prácticamente continua, solamente hay una pérdida de menos de 0,05 Lormar. Esto sería casi solamente 3 letras de una línea. Entonces estaríamos hablando de las monótonas, ¿vale? De las continuas. Full range of field continuos. Si la caída entre lejana, intermedia y luego subida cerca es menos de 0,14 Lormar, esto es menos de una línea y media, estaríamos hablando de las smooth, porque la caída es smooth, suavizada. Y la caída steep, la gran pronunciada entre lejos, intermedia y cerca, si es más de una línea y media, estaríamos hablando de las steep, que estas serían las bifocales de toda la vida. Las steep bifocales de toda la vida, las smooth, las trifocales antiguas, y las continuas, las que la ISO propone como full visual range. Estáis viendo aquí completo totalmente el global consensus que proponemos, con la nomenclatura completa, con la abreviada que os proponemos desde la SCRS. Y gráficamente, mirad qué simple. Las parcial, las que se quedan cortitas, las narrow, serían las monofocales, un poquito más las enhanced, un poquito más las extended, y las full visual range, las que tienen un descenso continuo, las que tienen un descenso smooth y las que tienen un descenso steep. Muy simple, nos iremos acostumbrando, y fijaros, estas son las terminologías, la similitud entre ellas, ¿no? La concordancia, la correspondencia entre nomenclatura óptica, con estándar, con la clasificación funcional y con la que se propone de la SCRS con un nombre abreviado. Y diréis, fantástico trabajo, Joaquín, muy chulo, pero ¿por qué no habéis metido fenómenos fóticos y fotopsia? Lo intentamos y no fue posible, porque la magnitud de la variabilidad es mucho más larga, es mucho más grande que el efecto. del tamaño del efecto, y esto probablemente sea, vamos, no probablemente, ya lo decimos, es por la variabilidad en el reporte, la falta de estandarización. Recordaros que el año pasado propusimos también en otra editorial de JCRS, con los editores de JCRS, el estandarizar la recogida y el reporte de estos resultados, y esperemos que en los próximos papers podamos incluir también en la clasificación esta información que nos parece trascendente y que sería tan importante para vosotros. Toda esta información la tenéis en la aplicación que hemos desarrollado, ya sabéis. El EOL Evidence lo tenéis en Apple Store, tanto en iPhone, iPad y Mac. Sabéis que tenéis una versión gratuita y otra Pro, es poquito dinero, y el poquito dinero que se consigue va directamente a la Fundación Elena Berraquer, que ya sabéis que se dedica a la erradicación de la ceguera evitable por catarata. En el glosario, que vaya a tener todas las lentes que salen al mercado, en cuanto salen, las vaya a tener en la aplicación. Y también vaya a tener en la aplicación donde están incluidas en cada una de las clasificaciones, y quizás lo más importante es que os vamos a añadir un criterio de escala en 6 niveles en función del nivel de certidumbre. Al fin y al cabo, el nivel de evidencia que se va generando en literatura científica en función de cuantos más papers salen de esa lente dando resultados aplicables a ese grupo, y sobre todo si el nivel de evidencia es alto, si es más riguroso el paper. En función de que puedan cambiar a la literatura científica, sacaríamos o no las lentes de cada grupo. Bueno, pues estáis viendo aquí todas las que hay en el mercado europeo en Hans. Los criterios, como hemos hablado antes, y cuál es la compañía que las realiza, el mecanismo de acción, el modelo, el material y el nivel de certidumbre. En este caso, esta lente que veis aquí es la que tiene mayor grado, mayor nivel de certidumbre de evidencia. Cuando estamos hablando de la Extended, la antigua EDOF, ¿vale? Las Partial Range of Field Extended. Aquí tenéis todas, veis cómo hay algunas con muy alto nivel de evidencia, otros con alto nivel y algunas con ningún nivel de evidencia, simplemente han salido al mercado. La compañía dice que propone que se metan ahí, las colocamos, y en función de que la literatura científica vaya generando evidencia, si se confirma la mantenemos y si no la sacaremos, obviamente. En cuanto a la Full Range of Field continua, fijaros, es un grupo que recién sale al mercado, ¿vale? Es muy pequeñito, ha sido definido por la ISO recientemente este año, ¿vale? Y fijaros cómo todas pues tienen muy poca certidumbre, obviamente, quizás esta es la que tiene un poquito más, porque es que están recién salidas al mercado. Tenemos la Full Range of Field Smooth, la Smooth Transition. Fijaros como aquí sí es más numerosa, tenéis algunas con muy alto nivel, y tendréis también las Steep. Estas son las antiguas bifocales, muchas de ellas no tienen evidencia porque ya quizás son lentes que no se implantan tanto.
Thank you very much, Joaquin. Excellent introduction. And now my colleague and dear friend Maria Gesa will introduce our next distinguished speaker, Maria.
Yes, this time Dr. Jel Offer is going to talk from optical design to bench analysis, whenever you want, Doctor.
Ladies and gentlemen, good morning. It's my pleasure to talk about my experience with the intensity trifocal lens from Hanita. I will give you some insights on the optical design and what we did at the optical bench analysis. So we all know that there's a lot of choices for the refractive or for the cataract surgeon in terms of premium IOLs, and especially the trifocal lenses have a long tradition, and there are a lot of products now available. We know in former times we had to look for a specific patient that fits to an intraocular lens. Nowadays we actually have to go the other way around and look what kind of IOLs would fit this individual patient. And there are a lot of criteria where we have to look for a patient selection, the medical condition, refractive status, preferences, profession, and even the personality are important, because our patients are getting more and more demanding, and so we really have to perform. So what is new here with the Hanita? It's a new technology, dynamic light utilization, DLU, which is artificial intelligence derived. What they did is actually they let the IA run different patterns for diffractive pattern in order to see what would be the most effective way to get from these patterns most effectively the light into the different areas. How can we distribute that, having most light out of it and less dysphotopsia? And the algorithm was pretty smart actually, and got a very good and efficient So the Hanita intensity is actually a pentafocal IOL, diffractive and spherical aberration adjustments. The light is utilized to go from multiple foci, amplifying the utilization of the light and reducing halo in theory and also in praxis. You can also see that you go to minus second order and plus second order. Some other lenses go from 0 to first to second order. So there's a different way to use diffractive system here. If we look at the light distribution, you can see here that in terms of the aperture, so the pupil size, at a small pupil of 2 millimeters, usually when you read, we have that most energy goes to the near. 50% goes to the near, then 40% to distance, and just a small amount to intermediate. It all changes very rapidly if you go from 3 to 4 millimeters. Then you have a classical trifocal distribution with most light going to the distance. And interestingly, intermediate and near never are different. They are around 20% of light perception, light utilization in this system. In other lenses, you have it differently, actually. Intermediate always gets less amount of light energy. And you see that this way, the intensity only loses 6.5% of light, of the light energy, and it looks much better than the other competing lenses. Especially if you compare AREA24 and the fine vision, you see the difference in how the light is distributed through distance, intermediate and near, as you can see here. We can use actually optical bench to foresee or look at different features of an optical system. Most of the time we use the modulation transfer function to describe the optical quality of a system, which we have done here also in a comparative study, comparing the panoptics, AREA24, intensity and synergy, as you can see here. When we look at the MTF results, we look first at a given pupil size, so 3 millimeter. Here you see that the intensity lens is more or less competitive to all the other lenses and have a very similar MTF performance and optical quality. If we go at the 4.5 millimeter aperture, we can also see that intensity is equal or similar to all the others, so not inferior. Interestingly, if we look at the defocus curve, we see that in the intermediate range here between minus 0.75 and minus 1.25, the intensity is better than the other lenses, outperforms them, and this actually gives you more even and more straight defocus curve in clinical situation. You will see that later on with the intensity, and we have also seen before that they attribute quite a bit of light to the intermediate range. Here we have the simulated visual acuity in relation to the defocus, and again we can see that in the intermediate range, minus 7.5 to minus 1.5, it is superior to the other lenses. We also use the lens also in a clinical study, or are still working on a clinical study, so many patients we have already included, and the outcome is pretty good actually. We are at logMAR 0 in all distances uncorrected and have a very broad defocus curve. You see here over a range of 3 diopters, everything is larger than 0.1 visual acuity, and after 6 months the same. Also the defocus curve gets better actually, even extends. After 12 months now, also excellent outcome, so it keeps the data, and even the defocus curve grows another quarter of a diopter here, as you can see. So we are very happy with that. Very low amount of halo glare, you can see here. Intensity as well as size of halos is fairly low, and there's almost no glare to be seen. So in general, we have very good results for uncorrected distance, corrected visual acuity at far, intermediate and near, and they're confirmed by the defocus curve testing. Excellent defocus curves of binocular in the clinical situation, minimal loss of light, 6.5% only, with a rapid neuroadaptation and high levels of patient satisfaction. So thank you very much for your attention.
Thank you very much. Your excellent talk and impressive results about the optical bench study. Now the clinical data will be provided as a complementary information to the one provided by Gerald by Germán Bianchi from Argentina. Clinical experience with intensity. What results can you expect? Thank you, Germán. You are the next.
Well, hello, everyone. Thank you for your invitation. It's a real pleasure to be here. Thank you, Dr. Alio, for the invitation. Today, I will talk about my clinical experience with the intensity. What result you expect with this IOL? Well, the first thing that I want to say is my experience about this Hanita IOLs. I started in 2016. I use more than 4,000 monofocal spheric IOLs, near 1,000 of full range. Now, today I have more than 800 intensity, and also I use a lot of the toric version of intensity. Since August of 2020, till now is more than 6,000 eyes implanted with Hanita lens. And this is important because I trust in this platform, I trust in the material of the IOL, and this is also important. It's not just the optic and the diffractive design and all of these things, no? Well, now we know that the IOLs can have different kind of light distribution, fixed, variable, and this lens has another different light distribution. Is the dynamic light distribution. This is the algorithm that explains how it works, but it's difficult to understand, but also all of these things have the combined design, split light across the focal distance using diffractive and refractive zones, light optimization, aberration control, dynamic light management, deep and focus improvement, and also adaptability tolerate to the common visual need through the statistical light usage analysis. And well, this is the MTF. The MTS is important for the normal pupil, 3 millimeter pupil. We can see here the far, the intermediate, and the near. And also we can see here the two intensifiers between intermediate and far and intermediate and near, and also in different with different size of pupil, we can see that it's maintained with 4.5. This is important for the night vision, the visual for far, for intermediate, and also for near. But also we need to study all of this kind of patient, and we need to know not just the main characteristic of the IOL, the diffractive rings give the distant and near vision, and the refractive ring gives the intermediate vision. But we need to evaluate our patient, and my clinical study are in two ways. This is the first study that I present in 2022, and a prospective study. I studied the safety, the efficacy, and the patient satisfaction of this patient. And you can find that in PubMed also. This was the focus score with very good focus scores for far, for intermediate, for near, and was a flat focus score. And very good visual acuity for distant, intermediate, and also for near. We can see here in the right. And also it was safe. This was with 6 months of follow-up, the spherical equivalent. We also studied the ACT, the CCT, the IOP in all of the patients in the pre-op 3 months and 6 months after surgery, and also the refraction in all of the patients. And well, this is the intensity, and a spheric IOL, and the posterior surface is diffractive. But always the patient asks to us, and not also the patient. We need to know, the doctor want to know if this lens is stable over the time. Sometimes the patient asks to us, doctor, how long will my surgery last? Will I always be able to see like this? How long does the lens implant last. But well, this is the evidence. This is a new study. The publication is in progress now. And the general aim was evaluate the performance 2 years after surgery. And the main objective was evaluate the binocular defocus curve and the visual acuity for far, intermediate, and near vision. And also the second aim was to evaluate the patient satisfaction 24 months after surgery. This is the design. It was with 60 patients, 120 eye. I did flags in all of these patients, and I studied visual acuity, the focus curves, like I told you before, and the patient satisfaction. And the visual for far was with very good uncorrected visual acuity, and also was with very good visual acuity for intermediate, 120, 80 centimeters, and also 66, and also for near vision, 40 centimeters. And also the patient satisfaction score was with very good, 98.6, with between 78 and 100, and obtained this total score in all of the patients. Well, the defocus curve in this patient, in this study, also was near to be flat, and we can see here the monocular and the binocular defocus curve, and it's near to the same when we compare it with another defocus curve with another doctors around the world, like we can see here. And this is important to compare it with another doctors. The patient satisfaction, the visual phenomena report with 0 for severe and severe visual phenomena report, like glare, halos, blur, vision for near and for far, and also with 0 of monocular and binocular diplopia. And also this kind of visual phenomena report was just one patient moderated, the other was, no one was severe in all of these visual phenomena report, and no one need to use glasses for near or for far, or for intermediate. Always, no one need to. Sometimes some patients need to use. And the important thing here is the very satisfied patient was 57 near to 100%, and just 3 was satisfied. And the other important question that I did here was, would you repeat the treatment with the same procedure? And all the patients say yes. This is important to know, all of these things, because we can have here the conclusion that far, the intermediate, and the near vision obtaining in all of the patients with the 5 foci IOLs allowed in the most of the patients not to use spectacles. And this is important for the 3 foci and for the intensify and reduce the halos, reduce the complication with the night vision, and also we don't detect any complication of this patient, and this data allows us to highlight the stability of the result achieved 2 years after surgery. And also, I always like to show that because this is the MTF with the patient with cataract before surgery, and we see here the internal MTF. We can see here how is the post-op MTF after surgery is with better MTF than the cornea.
Hi, I am Nora from Buenos Aires, Argentina. I am 65 years old, and 15 days ago I underwent surgery because of cataracts. Dr. Germán Bianchi implanted intensity intraocular lenses in me, and now I can say I am another person. I can see everything. I can read the smallest letters of my cell phone. I can drive. I can read the newspaper, everything. The only thing I can say bothered me a little bit was the hill of light I saw at the beginning, but it went away soon, very soon. Now I need nothing to see whatever I want to see, no matter the distance. I feel free, happy, and so grateful.
Well, I like to show this testimony because it's important to know how the patient feel. I also have the distributor of Hanita lenses that I put intensity in both eyes, and he is very happy too. Well, I like to invite at the same moment. I am now in this Congress in Oftalmo Córdoba, but I wake up very early to be here with all of you, and thank you very much. It was a pleasure for me. Thank you, Dr. Elio. Thank you, all of you. Thank you, Hanita Lenses, for inviting me to be a part of this.
Thank you very much, Germán. Excellent experience, and indeed very interesting to see the 2 years data that you have showing in your study. So the debate is open. We have Roberto Bianchi, we have Gerald Ford, we have Joaquin Fernandez, and we have here the representative from the audience, the young audience, the junior ophthalmologist, who is Maria Gesa. So you can ask any question as well, and we have some minutes for the debate. And my first issue is to share with you my experience with this lens. We have published, and it's accepted for publication this month, one study, prospective study that we did with this lens, and I can really confirm that the results that were offered by Gerard Alford and by Germán Bianchi were identical to mine. You know, we have added in our study the investigation of the quality of retinal image, because the quality of the retinal image clinical is different to the optical bench analysis, and sometimes we have disappointments when we analyze this quality of retinal image in inadequate conditions, obviously following implantation of different lenses, because the eye is an off-center optical system, and many lenses lose a lot of the benefits that they show in the optical bench when they are implanted in the eye. This is not the case with the intensity, and my first question is to Gerald Ford, because you have probably the most important studies in optical bench with different lenses. In your experience, we know that diffractive bodies are tolerant to decentration in part, to the eccentricity of the optical system. How was the behavior of this lens in the optical bench? Because we have clinical data, but in your case, the optical bench, to minor decentrations, because we cannot guarantee that obviously the lens center will be exactly in the place that should be with the visual axis. So which is the tolerance to eccentricity of the Hanita lens in your hands? Because this pentafocal design is very particular.
Yeah, we looked at the how robust the lens is in terms of decentration and so on, and it was very robust. It was for normal clinical situations, even decentration of 0.5 millimeter didn't really have a huge impact here in the performance. We were very happy with that. And also the design of the lens, the C-loop design in this case, has a very good centration. So in general, we were very happy with that on the performance. And if you go too much into correction of asphericity or something like this, like some of the competitors, you can have an impact on that. We also saw that in the Zeiss lenses, if you compare Atelier 3 with Elana. So this can have an impact, and we could see a very good performance here of the Hanita lens.
Very good, and we are lucky to have Roberto Bellucci. Roberto, good morning. Buongiorno.
Good morning.
From Alicante. Thank you. You know, well, we had 90% of our cases spectacle independent for all distances and very happy. Though the few ones that had sunglasses was because astigmatism. So my question to you, because you are an expert on this topic and you have your own ideas as well, how do you deal with astigmatism when implanted Hanita? Because all these lenses, diffractive, are sensitive to astigmatism, and the goal is to optimize the results, decreasing the astigmatism as well. So which is your approach when you use the toric model? How do you manage small astigmatism, for instance, 0.75, that should be, if possible, avoided following the surgery?
I have to say that before surgery, the astigmatism receives a special attention, as you said. I usually implant toric lenses whenever possible, even to correct for low astigmatism, because, as you know, even low, especially against the rule astigmatism, will increase in the post-op whenever we put the incision. So I prefer to use a toric lens. However, I have to say that in the post-op, the correction of the residual astigmatism is rarely performed. I cannot remember any case. Because we are looking for binocular vision, and if some astigmatism, I mean lower than 1 diopter, stays, from refractive astigmatism lower than 1 diopter stays in one eye, and the other eye has no or lower astigmatism, the patients are happy and they don't ask for the correction of this small residual astigmatism. However, as I said, astigmatism is something we should look at, and we should use a digital system to align those intraocular lenses. I prefer to use the bunny version of the Hanita, so I can rotate it on both sides at implant.
Very good. And Roberto, you showed to us, your idea about having a low power toric lenses, and you can modify the position of the lens according to the post-op astigmatism. Do you still use this idea just to target astigmatism correction with the lens implanted already on a toric lens of 1 diopter?
Yes, I do, because as you know, even spherical corneas, anteriorly spherical corneas, provide against the rule astigmatism in the posterior surface. And the power of the 1 diopter lens at the spectacle plane is in the region of 0.5, 0.7 diopter correction. So years ago, I was convinced that spherical lenses could be removed from the market. Now I think that this is probably a little bit difficult, because it would require on the doctor's side precise calculations before surgery that probably not all the doctors are prone to do. However, I think almost all the multifocal lenses now are available with the 1 diopter cylindrical correction that specifically refers to low astigmatism.
Very good. This is Roberto Bellucci approach to the correction of astigmatism with this lens, which is offering toric powers from 1 diopter. And now to Germán Bianchi. I have enjoyed very much looking at your 2 years data, and I have implanted the Hanita lenses for time. And you know, one of the specific advantages that I see is the low degree and low frequency of PCO. PCO, I have not performed a single YAG laser in my series of cases, the one that we published about the intensity lens. So at 2 years, which is your rate of PCO requiring YAG laser capsulotomy? Because this is an advantage as far as many patients are from far away and they have this opacity. They feel disappointed after 1 year or even less time, depending on the lenses, when they have to go to another doctor, to you, because low vision. What is your approach, and which is the frequency of this finding PCO in your intensity lens study?
It's a very good question. Thank you very much, Dr. Elio. And it's near to 2-3% just in 2 years after surgery, and it's very low. And I think it's because of the age of the lens is very sharp, no? I think is one of the reasons. And also, I use about the Roberto Belushi astigmatism. I use the other model, not the bunny, the plate, and I use a lot of toric when I see the astigmatism, the low astigmatism in the topography, because the patient have less halos when we use this kind of toric version, in this case. And I think it's very good. But also the plate is very safe. I like this model too.
Very good. Thank you very much. Well, I think that the time is over, and I can summarize, number one, that this is a patient that provides high patient satisfaction, but second, provides high doctor satisfaction, which is very important. I am very satisfied with implanting this lens. I am offering this lens when the patients want to have good vision for near. No question about near vision is going to be accomplished, but not at the cost of far vision. This is important, and indeed, I want to congratulate Hanita Lenses to bring into the market this interesting and impressive lens in terms of near, intermediate, and far vision behavior, providing high patient satisfaction and high doctor satisfaction as well. I want to thank all of you, Joaquin, Germán, and Roberto, my dear friend, and also Maria Gesa here, our junior representative of the audience, and Hanita Lenses to sponsor this session, which is in the benefit of our indications and in the benefit of our patients. But I want to thank you very much, and indeed I am happy that we could share this Saturday morning in the sunny environment of Alicante together with so many friends from so far away. Thank you very much, and the session is closed.